Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Harmony. ADHD and sleep loss share some common features: inattentiveness, loss of focus, and impulsivity, yet sleep is not part of the diagnostic criteria for ADHD. Sleep disorders in children may not present with hypersomnolence, but rather hyperactivity. How are ADHD and sleep connected? Dr. Jared Saletin is a sleep researcher who is exploring how sleep loss impacts attention. His research focuses on how sleep may be a modifiable risk factor for ADHD in children. He is the director of the Sleep and Circadian Methods Research Core in the Center for Sleep and Circadian Rhythms in Child and Adolescent Mental Health. He is also an associate professor of psychiatry and human behavior at the Alpert Medical School of Brown University. Welcome. I'm glad you could join us today.
Hi, happy to be here.
So, tell me about the diagnostic criteria for ADHD and ADD.
Certainly. Attention deficit hyperactivity disorder, ADHD, is one of the most commonly diagnosed neurobehavioral conditions of childhood, right? And it presents from a cluster of different symptoms that kids and actually adults might present in really two domains. One is inattention and the other is hyperactivity and impulsivity. And different kids and adults are going to have different combinations of these features. But, a clinician, a pediatrician, or a child psychologist would be looking for signs of inattention, losing track of their daily activities, diminished attention, the inability to focus on their schoolwork, maybe bursting out answers or being overly talkative, inability to stay still in class. And if you look at these symptoms, one thing that you might have thought was, well, I don't hear sleep.
Right.
I don't hear sleepiness. Right. But I was drawn to ADHD originally, and I'm not a child psychiatrist nor a clinical psychologist. I'm a cognitive neuroscientist. And I was drawn to ADHD because when you go through that list of symptoms, they look like someone who's getting insufficient or inadequate sleep. That loss of attention, that hyperactivity and hyperimpulsivity, those are the cardinal features of sleep loss. And that was really the enigma that opened up this line of research for me and many of my colleagues in this space, is this overlap between the phenomenology of this very prevalent child disorder and then what we know happens to an individual when they get inadequate or insufficient sleep.
So how does sleep play into this?
Yeah, and if you look at children with ADHD and you talk to their caregivers and you talk to their providers, you'll find out very quickly that sleep is part of the story. Children and parents will often talk about restlessness and inability to fall asleep and inability to stay asleep. There's actually some evidence to suggest that circadian rhythms might be altered in ADHD. There might be an exaggeration of evening phase preference that alone contributes to the inability to fall asleep. If you look at the adult literature, there's some discussion about how there might be subtypes of ADHD with and without insomnia features. And then also some, or rather many, children with ADHD, when they present to their pediatrician, are often evaluated for obstructive sleep apnea because there's a link there as well, that those ADHD symptoms might be masking underlying OSA as a function of enlarged tonsils and adenoids. And there's actually some brilliant treatment work to show that if you resolve that OSA, you can ameliorate or improve the ADHD symptoms, if not fully remedy them. So the relationship between ADHD and sleep loss or sleep fragmentation has been well described for many years, but it's a complex relationship. It's not one-to-one.
Well, and it sounds like you're describing prior to diagnosis, right, about the insomnia. What I was thinking about is the stimulants and, treating the ADHD and how that might be part of the insomnia, or does it actually make it better?
That's a great question, and we actually don't have as much data as we probably should on the direct influence of ADHD medication like methylphenidate, other stimulants, and even non-stimulant classes on the subsequent sleep that children experience. Although I think there are some clues there, right?
Mm-hmm.
Particularly some of these long-lasting stimulant classes kids take in the morning before they go to school. And that very well might be disrupting the sleep that night. Many kids with ADHD also take melatonin in the evening to help regulate their sleep. And so I think you're really pushing and pulling on the sleep system, right? You're getting a stimulant in the
Yeah.
morning, you're getting a chronotherapeutic in the evening. The two things are possibly sort of fighting against each other. But remember that the stimulants are prescribed for ADHD not because of a sleep problem. They're
Right.
prescribed because of a behavioral problem,
Right.
right? They're prescribed to help regulate attention, regulate hyperactivity. What happens to sleep is really secondary to that. But I think as sleep researchers, we have an opportunity to consider sleep as part of that equation. And that's where, if you look at, we talked briefly a few moments ago about obstructive sleep apnea.
Mm.
If you look at the data on obstructive sleep apnea and ADHD, the differences that can be gained by treating OSA that co-occurs with ADHD can sometimes make the dose of stimulants required less to get the same behavioral effect, or actually erase the need for stimulants for some of those mild, moderate cases of ADHD. So
Oh, that's
sleep plays
interesting.
a role to play here.
Well, and it sounds like then they would have received a diagnosis for ADHD and then subsequently received a diagnosis for obstructive sleep apnea.
I think it depends on who's seeing the child at the
Mm.
right moment in time, right? And many kids receive treatment for ADHD from their primary pediatrician. And if that pediatrician, is well versed in some of the symptoms of a sleep problem or a sleep
Mm.
disorder, getting that kid referred to a sleep clinic for a differential between sort of ADHD and ADHD with some of these sleep components can make the difference for treatment.
I'm actually really surprised that sleep isn't part of the diagnostic criteria, or at least part of the assessment for ADHD, because for some reason I thought that there was a shift toward looking at that before you rendered a diagnosis of ADHD.
I think it's about having, working with pediatricians and psychiatrists um, who are not sleep physicians
Mm.
to bring sleep into their frame of reference.
So talk to me about your research.
Yeah, so we really sit at the intersection here, not clinically.
Mm.
Again, I don't treat children with ADHD, but trying to understand that similarity between these two states, right? This idea that a child with ADHD at a behavioral level manifests many of the things that we would expect if we're insufficiently slept, right?
Mm.
And when we talk about children and adolescents, we know that sleep is at risk for many youth, particularly in this country. Um, you know, Understanding that, as kids go through adolescence, there are all these biological changes to their sleep and circadian regulatory systems. And all of that comes directly at odds with early school start times and other societal forces. So we have sleep changing in the evening. We have society putting limits on when kids can sleep in the morning, and kids lose sleep.
Mm.
The average teenager in this country loses about 2 hours of sleep a night at the worst period of adolescence. And that's about 10 hours of sleep a week
Mm.
for a high school student gone from their sleep regulatory system. And we've spent so much time talking about what the consequences of that insufficient or inadequately timed sleep is for teens, for cognitive ability, for learning, for memory, for emotional regulation. But then if you stop and think, well, who are these children? If 1 in 10 children in the US have some level of attention deficit hyperactivity disorder, how are those kids experiencing this very prolific sleep loss,
Mm.
right? And if those kids with ADHD already appear sleep, rather, if those kids already appear sleepy in their behavior, well, what happens when they go through adolescent development and they go through early school start times and their
Mm.
sleep is compromised? Do they experience the same deficits? Are they more vulnerable to those effects because they're already in an inattention or hyperactivity vulnerable state? That intersection between the sleep loss that we know many, if not all, youth in the US and elsewhere will experience during adolescence as a function of biology and society. How kids with ADHD might go through that process is really the fundamental question that my research is trying to answer, trying to understand vulnerabilities and resilience factors that help determine how the brain and behavior of youth respond to insufficient sleep, such that hopefully, if we can identify some of those factors, we can do something about it.
So tell me more. What did you look at? How did you do it? What did you find?
Yeah, so in the paper that we're very excited is coming out in the journal Sleep, we sought to ask this question in an early experimental study. So this is a small pilot study. These are kids ages 10 to 13 with a range of ADHD symptoms. So some of them sort of are fully clinically representative of a typical child with ADHD. Some of them are in the subclinical range, but experiencing sort of differences in inattention and hyperactivity. And we asked a very simple question. What happens to the brains of these youth when we take sleep away experimentally? And we took sleep away using a very strong experimental probe. Kids came into our study after sleeping at home for a week. If they were on ADHD medication, they were taken off for that week. And we stabilized their sleep to about 9.5 hours a night. So this is a really strong sleep schedule for an early adolescent. They then come into the lab for 2 consecutive nights of polysomnography. The first night on that same 9.5 hour sleep schedule. So for most cases, kids were going to bed at 9 o'clock at night, waking up at 6:30 in the morning. We tried to pick something that felt very similar to a typical school week schedule. Had to be up for about 6:30 because that's when kids have to go to school, right? Well, that was the first night. On the second night, they come back to the lab, and the only experiment is that we don't let them go to bed at 9 o'clock. We keep them up. And we keep
Okay.
them up till about 2:30 in the morning.
Oh, wow. Okay.
So for a 10-year-old, right, that's pretty late. And I'm really owe it to our research assistants, many of which, students who stay up with these kids, and we watch movies and play games. There was a lot of Harry Potter. There was a lot of popcorn. And kids are usually okay with it. It's kind of like a sleepover in the lab.
Yeah, it sounds like fun.
It is fun. It's a little bit harder for me and at this point to stay up to that late. But the kids actually do an okay job at it, and we have some great students that help them along the way. And then the kids are allowed to go to bed in the lab, again monitored by polysomnography, and sleep into that same 6:30 wake up time. So we've cut sleep down to 4 hours from 9.5 on that second night. So a direct homeostatic challenge, right? An extended wakefulness challenge. And then after both conditions, kids were picked up by their parents and brought over to Brown University's MRI research facility for a research grade fMRI or functional MRI scan so we could look at brain connectivity the next day. And when I say brain connectivity, what I really mean is what we call in neuroscience functional connectivity.
Okay.
How well the areas of the brain are talking to one another. And looking at that fundamental architecture, many of your listeners might be familiar with words like resting state networks or default mode networks. These are sort of the networks of the brain that play sort of underlying roles in how we process our cognitions, our motivations, our emotions, our thoughts, feelings, our actions. This is the underlying architecture of the brain. And by putting you in an fMRI and just asking you to relax, not asking you to do anything, we can actually sort brain activity into these distinct networks. And we wanted to see how that one night of insufficient sleep altered the connectivity of those networks in these kids, and then whether kids with more or less ADHD severity might experience that change in brain connectivity differently.
And so what did you find?
Well, we found out that that's exactly what we observed in the data. One of the amazing things about the brain is how sophisticated its architecture is, right? And just to take us on a metaphor for a second, if you were flying, I'm here in Providence, Rhode Island. If I wanted to get to San Francisco, I probably would have to go through a hub, right? Because there's not enough traffic from Providence, Rhode Island to San Francisco, as much as I would love there to be. I went to grad school in the Bay Area. So as much as I would love a direct flight, there isn't, right? I have to go to Chicago or North Carolina or DC or elsewhere. And we've built that network of traffic in this country to have these sort of hubs of regional connectivity and then hub to hub long range connectivity for efficiency, right? It makes travel efficient. Well, the brain is exactly the same. It has what we call small world organization. It has these hubs that have connectivity to areas of the brain that it needs to speak to, and then long range connections between networks. And so we can actually operationalize and compute the degree that network architecture is intact, how modular the networks are, how efficient they are at this balance between this sort of hub-like organization versus something that would just have connections all over the place. And we call that modularity, brain modularity. And our data show the same thing that's been shown with total sleep deprivation in adults, which is that a pressure on the sleep system deteriorates brain modularity. All of a sudden, again, using the airplane metaphor, all of a sudden cities that should have connections start to lose their connections, and cities that maybe are not efficient to have connections with one another start to gain them. The system starts to break down.
Oh, okay.
It's harder and harder to get from one network to the other because the balance between integration and segregation begins to shift. So we showed in our 10 to 13-year-olds that can happen in the fMRI signal after only one night of insufficient sleep. Again, keeping you up till about 2:30 in the morning and giving you only about 4 hours to sleep that second night. But that's not all we saw. What we also saw is that children with higher symptom levels of inattention hyperactivity actually had the greatest change in that brain structure. Suggesting that those kids might be more vulnerable to the brain's consequences to insufficient sleep. And that was really exciting for us because we know in adults that there are many factors, such as genetics, that can distinguish one's vulnerability or resilience to sleep loss at a behavioral level. We know less about factors that do the same for children. And here you have something like an ADHD symptom that is easily identified by teachers, easily identified by pediatricians, that says something about how that child's brain is going to respond to a night of insufficient sleep.
So let's take a short break, and when we come back, we'll talk more about sleep and ADHD. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Are you looking for treatment options to add to your clinical practice? Learn about Wakix pitolisant tablets. I'm Dr. Chris Winter, and I've been practicing medicine for over 20 years. Why include Wakix as a treatment option in your practice? Visit wakixhcp.com today to find out more from me and other clinicians who have prescribed Wakix. That's wakixhcp.com.
Welcome back to Talking Sleep. We're talking with Dr. Saletin about his work on how sleep impacts children with ADHD. So help me understand this. So sleep loss worsens existing ADHD, or does it cause ADHD?
That's a great question. We don't know the answer to that question. What our data show is that sleep loss might be setting up the brain for ADHD-like brain states. Because the other piece of our paper that we showed is actually that the change in that brain modularity that I referenced also predicted the change in reaction time the next day.
Okay, that makes sense.
right? There is a behavioral link, but we're not causing ADHD in the laboratory. I want to be very clear about that. What we don't know, however, though, ADHD is a developmental disorder in many contexts. It has to sort of onset by about age 12, but it's been associated with different developmental trajectories of cortical function in the brain. There's a widely known sort of premise that some kids with ADHD appear to, quote unquote, grow out of the disorder as they get older. And there might be some science to back that up, that, those developmental trajectories might be on different timescales, but eventually converge. And then some of the difficulties that are associated with ADHD might not be as present. That's not every child with ADHD. There are some issues that might persist into adulthood. But when you think about anything as a developmental process, well, sleep is developing and changing during that same window of time, right?
Sure.
So capturing these sorts of things only in cross-section of one study really can't answer that question. And if we look, early in childhood, we know that sleep, even in the first couple of years of childhood, is now predictive of longitudinal outcomes and neurocognitive outcomes and presence or absence and type of neurodevelopmental conditions in childhood. Not a one-to-one link, of course, but some explanatory variance. So I personally think that, there likely are developmental links between how a child sleeps, not just duration, but timing, regularity, efficiency, quality, and the development or progression of neurodevelopmental conditions such as ADHD. And I say such as ADHD because there's a number of comorbid conditions that kids can experience on other behavioral domains. ADHD is just one slice of that.
Okay. I was wondering why you were saying that. Okay. So is it that people with ADHD are more sensitive to sleep loss?
That's our working hypothesis.
Okay.
Because of this similarity between the behavioral phenotype and an individual that is sleep restricted or sleep deprived. And actually, we did a study a couple years ago, which was a meta-analysis, where we took all the fMRI studies of executive function, working memory, things that depend on the frontal lobes. And we took the ADHD literature. And these were studies that were comparing individuals with and without ADHD. We took that literature and we compared it to the literature of total sleep deprivation. So these were studies that took largely adults and compared a rested brain to a totally sleep-deprived brain.
Okay.
Now, the first thing that's interesting for our sleep field is that there are about an order of magnitude more ADHD fMRI studies than there are sleep deprivation studies. So we have some work to do.
I was going to say that makes sense. I get that.
It does make sense.
Yep.
Now, the other thing that I think is interesting from a sleep researcher's perspective is almost none of the ADHD literatures mentioned what the sleep history of the people they were studying were. And, so we talked about, clinicians asking their patients about sleep. Researchers need to ask their participants about sleep as well. Because
that's
we don't
fair.
know,
Yep.
we don't
That's
know, necessarily the folks with ADHD or controls in those studies, what their sleep history was. But if you put those two literatures head to head with one another, you actually get an empirical Venn diagram in many areas of the brain showing that there are areas of the brain empirically that are indistinguishable between an ADHD brain and a sleep-deprived brain.
I wondered. Okay.
Now, it's not every area of the
Yeah.
brain, but it is areas that control some key cognitive, attention, and hyperactivity regions. And we interpreted that as part of the reason why the behavioral phenotype of ADHD looks a lot like someone who's sleep-deprived. Well,
Yeah.
because they hit the same region.
Yeah.
So if they're hitting the same region, what happens when I then sleep deprive you? What happens when I take sleep away? Are you more vulnerable because you're already in that state?
Like a double
And that's
whammy.
been our working hypothesis. And this paper that's just coming out is some of the first data that we have to support that hypothesis.
So then, if you have a kiddo that is pretty resilient to sleep loss, is that kiddo also resilient to ADHD?
I don't know. I don't know exactly how to answer that question in terms of what it would mean to be resilient to
Yeah.
ADHD. But I think you're touching on something that's really critical and important for us, which is we know many youth are going to experience sleep loss during childhood and adolescence. Again, some of it is biology in terms of changes to the homeostatic system, changes to the circadian system that push their sleep later. And some of it is outside their control when we schedule school, right? So the two of those things combined, sleep is impaired.
Mm-hmm.
Not all kids are walking around with an inability to pay attention in class, an inability to do the tasks that they need to do. Many kids, even kids that are struggling with their sleep because of those factors, are doing just fine during the day.
Mm.
So if we can find ways to identify those kids that are resilient or vulnerable, then we can have child-centered education approaches. We can have child-centered interventions at either a child level or a policy level to try and help the kids that we think might be having a hard day because they're insufficiently or inadequately slept.
Well, and so I heard you say a couple of things, right? You've touched on sleep duration, but then I also heard you say that maybe there is this delayed sleep phase chronotype that is more prevalent in kids with ADHD. So then the timing of sleep becomes, like you're saying, with delayed school start times and things like that. So is it both?
It very well might be both. There's that, the interesting thing about ADHD and circadian rhythms is there is this perception of greater eveningness and potentially differences in the phase of circadian rhythms. And there is not a tremendous amount of data to suggest that that is absolutely true.
I'm also wondering about sleep disorders. You talked about sleep apnea, but what about narcolepsy?
That's a great question, right? Because if you look at, what is inattention hyperactivity, it very quickly comes up against daytime sleepiness. And so there are high rates of comorbidity, particularly of type 2 narcolepsy and ADHD in youth. To my knowledge, this has not been really well worked out in terms of, are there specific subtypes that have sort of emergent ADHD from the daytime sleepiness of the narcolepsy, or are there really sort of convergent mechanisms at play here? Is there a role for ADHD treatment in narcolepsy? I think these are open and interesting questions.
Well, that's really interesting that you say that. I read this article about, it was like a meta-analysis from China, and it was linking ADHD and narcolepsy. And I've actually reached out to the authors a few times, and I've heard nothing back because I would love to learn about this a little bit more. Because so many of our patients with narcolepsy that, of course, I see adults. And so a lot of them already carry a diagnosis of ADHD, but I often wonder if maybe is it the sleepiness that sort of led to the inattentiveness, and maybe just because we understand ADHD probably better than we do narcolepsy, is that why that diagnosis comes first? And could it actually be narcolepsy?
Yeah, Tom Anders, who's a child psychiatrist here at Bradley Hospital and Brown University, now emeritus, had a long-standing hypothesis that some of the hyperactivity in children with ADHD might be masking underlying daytime sleepiness. And that's really what you're getting at here. And this intersection between the two of them remains, I think, really worthy of study. Our study was 2 nights in the lab, and it would have been incredible if we had an MSN, an MSLT, or an MWT in the same laboratory study where we could maybe look at daytime sleepiness and parse what we didn't. And I wish we did.
So part 2.
Part 2, indeed.
2025 marks the 50th anniversary of the AASM. Here is Dr. Carol Rosen sharing her early experiences with the AASM and pediatric sleep medicine.
The Academy has, I think, overall had increasing support for pediatric sleep medicine. in some sense, I think sometimes we always felt a little bit on the outside, especially in our local institutions. I guess when you think about sleep medicine and local institutions, there was a sleep lab, and it was a great, I hate to use this term, cash cow for many departments, and it was sort of OSA-centric. But I think by bringing pediatrics in, you had to make the labs a little bit more welcoming for all kinds of people, accommodating caretakers, and caretakers not just for parents, but maybe caretakers who might have come with adult patients. I feel like pediatrics brings so much richness.
Now back to our conversation. This seems like a pretty robust link between sleep and ADHD and potentially, right, the trajectory of that child's, academic future anyway. And so what I'm kind of wondering is, outside of population-based regulations like delayed school start times, what else can be done to protect their sleep? Like, is this something you can get an IEP for?
I think that's such a provocative idea. If we think about things that one could in a future prescribe for a child, right? If you know that that child is not just underslept or insufficiently slept, but might be more vulnerable to that change in sleep. Well, could we prescribe homework to be of a certain load, of a certain timing, right? Could we prescribe in factors that buffer sleep? Early school start times are only one of the factors that contributes to insufficient sleep during adolescence, right? It's a major one, it's a huge one from a policy level. But it affects every kid.
Right.
What are the things that affect one kid? How much homework do they have on Thursday night? What time are their assessments on Friday? Are those assessments early in the morning? Are those assessments in the mid-afternoon? Could we use sleep and circadian biology to optimize the timing of those assessments the next day, such that even if you were underslept the night before, you might be at the most adept time to take the test the next day? I think as sleep researchers and as sleep professionals, we need to do both at the same time. We need to be talking to policymakers and advocates, and I know the Academy does this, and the Sleep Research Society and others do this as well, to make sure that we have healthy school start times for kids and teens. That's at a policy level. But then at an individual level, I think we need to be working with teachers and working with parents to help them understand the factors that contribute to children's sleep, and then understand what we can do to try and buffer sleep and buffer daytime behavior and give those kids, for whom society is controlling an aspect of their sleep, the best chance of success during the day.
Well, and I feel like when you talk about policy, to me that really hits on all of this conversation around standard time versus permanent daylight time. And the idea that if we have permanent daylight time, you in one fell swoop eliminate all of the gains from delayed school start time. And I'm not sure that the people voting for this or supporting this may not connect the two, right? And so then that's our job too, to add to this, national conversation around time change.
Absolutely. I couldn't say it better. I think, we have an opportunity here where the science is very clear about what is healthy for our bodies and for our minds. And, the difficulty of the daylight saving time debate is that it really is experienced differently by people in different parts of the country, right? And that is just an artificial reality of how we draw our time zones. And so working with folks from coast to coast, regardless of what your own day, night timing is as a function of where in the time zone you are, understanding that, across the country, universal standard time is healthier and more aligned to our body's internal rhythms and supports day-to-day behaviors to a healthy way. I mean, that is such a powerful and important messaging. And again, you sort of linked it back to school start times. If we change the clocks and schools are starting in darkness, it doesn't matter what we do to school start times, right?
It was funny. I testified at something in North Dakota at the legislature about standard time. And there were far fewer people advocating for standard time than there were for permanent daylight time. And the permanent daylight time advocates were bringing up issues that are very legitimate, when they talk about construction. So in North Dakota, Minnesota, our construction season is shorter because of our long winters. And there are covenants in neighborhoods that don't allow for noise, for example, before 7 a.m. And so then they talk about this local covenant that prevents them from extending their work time that they have to adhere to, but then they also have this really short construction time. And so I feel like, you can recognize both parts of that, and maybe there is a little bit of compromise to be had, because that's valid. I get that. And yet, it's really important for our children to get their sleep.
Yeah. I think the other thing is either already states, like Arizona, that opt out of the time change. And, if we're talking about policy levels and compromises, that might be on the table for some of these states because, I'm here in Rhode Island. We're towards the far east side of the Eastern time zone. We're in the same time zone as Detroit. And the light-dark cycle of here in Detroit are vastly different from one another. And I think we have to take that into account when we have these conversations. And when if you're in that, if you're testifying or at a public meeting on this issue in Boston versus in Michigan, you're probably going to get people coming to you with different perspectives.
That's a good point. You're right. So when you did your study, were there all the kids had ADHD, or was it sort of half and half?
No, it wasn't even designed to be half and half. This was a continuous sample. So there were some kids in the middle, some kids high, some kids low. This is, and so these kids, it's what we call a dimensional sample, trying to put kids on a continuum of symptoms. So there's more work to do. And really understanding whether this is about ADHD per se as a diagnosis, as a cluster of symptoms, as a threshold, or is this about something underlying that drives inattention and hyperactivity at a dimensional level? And future studies can get at that by sort of, comparing these dimensional approaches to more gold standard sort of case control designs where we take a really tight diagnostic group. But then also looking at heterogeneity. Kids with ADHD who also have oppositional defiant disorder or maybe conduct disorder, or even the comorbidity between ADHD and autism spectrum disorder, where there is, many overlap in the much overlap in the inattention and hyperactivity symptoms. So parsing all of that, is this really a disorder related phenomenon of vulnerability, or is this something at a trait level that's manifesting in inattention and hyperactivity? I think the jury is going to be out on that.
Well, I was curious about the kids that sort of were on the low to no spectrum side of ADHD and how they changed with sleep loss.
Yeah, we didn't see anything that was apparent of sort of a U shape or an asymptote. It was really just linear. But we also had such a small sample that I'm hesitant to make much claim. It would be really interesting to think about whether or not, as you say, when you get to the far end of the opposite side of the spectrum, kids that have sort of an incredible ability to focus, very little impulsivity at all, does that alter their resilience or vulnerability in either direction, right? Are they more rigid in their ability to respond to sleep loss, or are they more protected from inattention? I think both of those could be interesting hypotheses to follow through. So, that would be a really interesting study. We often talk about these types of studies in terms of vulnerability, right? What factors make you respond worse when you get insufficient sleep? But it is equally interesting to ask from a lens of resilience. What factors protect you when you experience insufficient sleep?
Yeah, because I would love the punchline to be, that you have something very valuable to offer a patient in terms of addressing their sleep to not only improve their sleep, but then maybe also improve some of their ADHD symptomatology.
Yeah, and that would be a wonderful experiment where you would, sort of put the actual sleep intervention into play here, right? So you could do something very similar to what we did, do a drastic homeostatic challenge, identify the kids that might be more vulnerable. Then let's put them into an intervention arm and structure sleep and see if we can actually create that child-specific intervention. That would be an exciting opportunity to do.
Well, it kind of reminds me of a patient I saw when I was a fellow. And, you walk in the room and the dad is like zonked out asleep, snoring, right, in the chair. And he's got these like kids literally climbing the walls of the waiting room. And, when you talk to the mom and you ask about the kid, the mom was like, oh yeah, the kid snores way worse than his dad. And of course the dad had sleep apnea, right? But to me, that was oh wow, this kid also has sleep apnea and dad's zonked out asleep and the kid is climbing the walls. And so just to kind of examine all the faces, right? All the different symptoms, the spectrum of symptoms you can have from sleep disordered breathing and disrupted sleep.
Absolutely. And I think from the kid's perspective too, identifying that early when a child is young, I mean, you're really talking about the potential to make lifelong improvement on quality of life, right? We often think in developmental sciences of if you could identify something when a child is young, the angle of change seems small when you're a child, but if you project out 20, 30, 40 years, that angle can create real dividends and pay off for health in some profound ways. And so I think that's, critical about why we need to protect sleep for kids. I mean, it's such a vulnerable window of time where the brain and behavior is so plastic and health is so modifiable, so that we can create this healthy brain and body state long into their adulthood. And so if you have a child with ADHD who hasn't been evaluated for sleep, and then getting them evaluated for sleep. I mean, not all kids with ADHD are going to have a sleep disorder. By no means is that true. But for the kids that might have a latent sleep disorder, be it obstructive sleep apnea or something else, taking care of that can improve their ADHD symptoms today. But of course, is going to have long-term consequences for, we take care of obstructive sleep apnea for kids. The kids are going to sleep better all the way through their youth, their teenage years, their early adult life. And that's going to project out to healthy living over the whole lifespan.
Yeah, it's really meaningful, isn't it?
That's why I love studying sleep in kids, because we often will talk in terms, again, about the negative consequences of policies of insufficient sleep and school start times. But sleep is such a powerful driving force for the health of children and adolescents at a time when we can do real good by bolstering that sleep and the health benefits that it provides.
So do you have a key takeaway for us?
I think my one key takeaway is that at a time when children and adolescents experience insufficient sleep, we need to be asking about what the consequences of that sleep loss is, not just in terms of grades and school performance. That's all important too. but what are the consequences to the brain's ability to do its job the next day? And how can we buffer that by identifying the kids that might be more resilient or more vulnerable to those effects?
Well, thank you for joining us today. I learned a lot about how ADHD and sleep are more interconnected and how improving sleep may ultimately improve ADHD symptoms.
I really appreciate the opportunity to share this work. And just a shout out to my colleagues who are clinical psychologists who treat children with ADHD on a day-to-day basis, because I'm leaving out all the clinical parts to this story. I mean, I'm really coming at this from the lens of the neuroscience of how the brain and ADHD come together. But, there's a clinical story to this too, the management of sleep and ADHD and the intersection of their clinical phenotypes. And I just want to give a shout out to my colleagues who do that work, because that's the critical work.
But isn't that great? That's what I love about our field. There's so much collaboration and I think people play nicely under this big gigantic tent that we have.
Absolutely. There's so much work to be done. So I really appreciate the opportunity to share this work with you and with your listeners.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.